Welcome to the presentation for Module 8, Nursing 150. This presentation is part 3 of Module 8 presentations, and we will discuss care of the patient with infectious disorders of the lower respiratory tract. And it's an important, always, just to continue to remind ourselves the function of the respiratory system, the assessment of it, and the importance of maintaining a patent airway so that oxygenation is always supplied to the patient. Remember, the respiratory system delivers oxygen to the bloodstream and removes excess carbon dioxide from the body. The respiratory system functions primarily to maintain the exchange of oxygen and carbon dioxide in the lungs and tissues, and regulates acid-base balance by doing this. Any change in this system affects every other body system. Changes in other body systems may reduce the lungs' ability to provide oxygen and eliminate carbon dioxide as well. So it's a very important body system that we have to maintain, that it's patent in order for the patient to survive. The respiratory system consists of the airways, lungs, bony thorax, and the respiratory muscles, and functions in conjunction with the central nervous system in order to initiate our breaths. So there's a lot involved here, and this is just a review. These structures work together to deliver oxygen to the bloodstream and remove, again, the excess carbon dioxide from the body. It's important to understand the respiratory system, the anatomy and physiology of it. For this presentation, we're going to discuss the lower part of the airways. The lower airways begin with the trachea, which then divides into the right and left main stem bronchial tubes. The main bronchial tubes divide into the lobar bronchi, which are lined with mucus-producing ciliated epithelium. One of the lungs' major defense systems is this ciliated epithelium. The cilia help to move debris and mucus out of the airways. The lobar bronchi then divide into secondary bronchi, tertiary bronchi, terminal bronchioles, respiratory bronchioles, and then alveolar ducts, and finally into the alveoli. This is where gas exchange occurs. The lungs in a typical adult contain about 300 million alveoli. That's a ridiculous amount of alveoli, but we have to keep them all healthy. The lungs share space within the thoracic cavity with the great vessels, trachea, esophagus, bronchi, and the heart. Each lung is wrapped in a lining called the visceral pleura. The larger of the two lungs, the right lung, has 3 lobes, the upper, middle, and lower, and the smaller left lung has only an upper and lower lobe. The diaphragm and the external intercostal muscles are the primary muscles used in breathing. They contract when the patient inhales and relax when the patient exhales. The respiratory center and the medulla initiates each breath by sending messages to the primary respiratory muscles over the phrenic nerve. So just remember, kind of going through this with you all just so you remember there's lots of things involved in proper breathing. The term pneumonia describes inflammation of certain parts of the lungs, such as the alveoli and the bronchioles. Pneumonia may be caused by either infectious or non-infectious agents. Examples of infectious agents are bacteria, fungi, and nonspecific viruses. Non-infectious agents may include irritating fumes, dust, or chemicals that are inhaled, or foreign matter that is aspirated. Nosocomial pneumonia is a hospital-acquired infection that may be attributed to inadequate hand washing, poor sterile technique with suctioning, contaminated equipment, and exposure to others who have infectious respiratory conditions. People who are most likely to contract pneumonia are smokers, those with altered consciousness from alcohol seizures, anesthesia or drug overdose, those who are immunocompromised, chronically ill people who are malnourished or debilitated, and people on bed rest with prolonged immobility. Infectious pneumonias are categorized as community acquired or hospital acquired, which means either they are admitted with a pneumonia or they acquire it as they're here for many different reasons, some of the reasons that I mentioned. Some other risk factors is just being an older adult, presence of other chronic comorbidities, and recent exposure to respiratory or influenza infections is some very common causes of pneumonia. An elderly patient that acquires influenza can easily develop into a pneumonia. The comorbidities that put a patient specifically at risk for pneumonias is chronic obstructive pulmonary disease. Sometimes patients with asthma, it can put them at higher risk for acquiring a pneumonia. One other thing to remember regarding pneumonia is an aspiration type pneumonia is when someone aspirates maybe a food or a fluid into their bronchial, not if they're having trouble swallowing. So with their difficulty, they are having trouble maintaining the muscles of their swallowing. So it could mean that some of their food is going down in their bronchioles, not into their esophagus. An aspiration pneumonia is more likely to occur in elderly patients, and sometimes this is associated with a stroke or other disease processes that might prevent them from having adequate swallowing ability. The patient will often present with a complaint of a frequent productive cough. They will also complain of fever, chills, sweats, some chest pain sometimes due to the frequent coughing, shortness of breath, sputum production, headache, and fatigue. Elderly patients may present with confusion, poor appetite, weakness, and sometimes their fever and cough is not as obvious in an older adult. Viral pneumonia is sometimes characterized by burning or searing chest pain in the sternal area, and a barking cough, producing small amounts of sputum and headache. People with a bacterial pneumonia may experience an abrupt, almost acute onset, severe shaking, chills, sharp pain with coughing, and then more of a purulent, productive cough with bacterial infections. This isn't always really obvious whether it's bacterial or viral, but there are a few subtle things that can point out to us if it's bacterial or viral. There's some talk here regarding bronchial breath sounds heard over areas of density or consolidation. This is when you hear bronchial breath sounds more on the bases and the outer parts of the lungs, because remember, you should only hear bronchial breath sounds around the upper part where the bronchioles are. Fremitus is often heard over air or palpated. Remember when you put your hands on a patient and have them repeat 99, fremitus can help you determine whether a patient has consolidation. Consolidation meaning that they have fluid or inflammation in their lung fields, because really all that should be going through those lung fields is air. Percussion is dulled when you're remember when you percuss, it's a dull sound rather than more of a hollow sound. That air would be a hollow sound. When there's fluid, inflammation, and secretions in there, it's going to sound more dull. Chest expansion may be diminished or unequal, and their work of breathing may be increased with a patient with pneumonia. Productive cough is usually a pretty distinct sign and symptom of pneumonia, especially if it's related to headache, chills, fever, and pain with coughing. Diagnosis of pneumonia is usually based on the findings of the history and physical exam. Make sure you review, you know how to assess a patient, looking at their oxygen level, skin, work of breathing, vital signs, things like that. It's based on, and then talking to them about their history. Sputum culture culture and sensitivity will help us determine if it is a bacteria and exactly what bacteria is causing it. A chest x-ray helps us to view the lungs and determine if there is an infectious process going on in the lung fields. A CBC can help us to determine whether someone has an elevated white blood cell count, which is indicative of infection. Blood cultures may also be performed to determine if an organism has invaded the blood. Remember, this can lead to sepsis if that occurs. Arterial blood gas, that's getting a sample of arterial blood, not venous blood. We typically get venous blood for most blood tests, but this would be an arterial blood, and that helps us to look at the oxygenation of the blood. We can actually look at oxygen levels in the arterial blood sample. And remember, the arteries is what takes oxygen to the tissues. So it gives us a good indicator of how much oxygenation is being taken to the tissues if we get a sample of arterial blood and test it. We can also test it for carbon dioxide levels. Carbon dioxide levels can tell us how well we are making a gas exchange and help identify a need for supplemental oxygen. We'll look at the patient's renal function as well to determine if there is also any dehydration. We can look at the blood urea nitrogen level because oftentimes patients will become dehydrated with pneumonia. Again, going back to chest x-ray may not show changes until 2 to 3 more days after manifestations are present, but you can usually see an increased density, which tells us that there is some inflammation and fluid related to the inflammatory process of pneumonia. The term atelectasis is often used for collapsed or airless condition of all or part of the lung. It is usually acute and commonly occurs at the same degree in patients undergoing surgeries, an airway obstruction, or just damage from an infection such as pneumonia. So atelectasis, just make sure you understand what that term means. It's usually referring to collapsed or airless condition of part of the lung, which can be seen on X-ray. Prevention is typically very essential to making sure that our patients do not get pneumonia. We talk about this a lot. We do this a lot in practice with our hospitalized patients. We do lots of different strategies to prevent a patient from getting a pneumonia. That's because the complications of pneumonia can be very detrimental on some patients. Patient education about vaccination is important. In the prevention of pneumonia, there is a pneumonia vaccine. Currently, the pneumonia vaccine is recommended for patients who have comorbidities that would be at risk for complications associated with pneumonia. Elderly patients are encouraged to get it, along with getting their yearly flu vaccine. There's a great chart in your book that discusses preventing pneumonia. A lot of that includes encouraging patients not to smoke or be around people who smoke. Any kind of irritant like that could damage the lungs and make it more susceptible to infection. Maintaining hydration, eating a balanced diet, activity, enough rest, avoid indoor pollutants, and things like that are lots of different strategies that we can educate a patient in the prevention of pneumonia. Nursing care can be reviewed in your book as well. There's a good, actually kind of a concept map that you can find in your book, in the chapter on care of the patients with infectious pulmonary diseases. Interventions such as making sure that we apply oxygen therapy when it's needed and monitoring and maintaining oxygen therapy. really nursing care is based on making sure that our patient maintains a patent airway and that our patient receives enough oxygen to the tissue to maintain homeostasis. Incentive spirometry is encouraged for the prevention and the treatment of pneumonia. It is used to improve inspiratory muscle action and to prevent or reverse atelectasis. Remember, atelectasis means alveolar collapse. Taking a deep breath in with your incentive spirometer helps to reopen all of those alveoli. Instruct the patient to exhale fully and then put that mouthpiece in their mouth and take a long, slow, deep breath in. Make sure you understand how to teach a patient how to do an incentive spirometer. What goes along with that is coughing. Make sure they do coughing and deep breathing. The coughing helps to clear the airway, and then the deep breathing helps to open the lungs. It also helps to exercise the muscles associated with breathing, which can be weaker when a patient is ill. Other medications may be given, such as antibiotics. We may be giving inhalers. We may be giving inhalers such as bronchodilators or steroid inhalers. We need to be able to effectively teach a patient how to use these medications and how to do them properly. Expectorants or decongestants may be given. We need to educate our patients on all those medications. The key to treating a bacterial infection is antibiotics. But we have to be able to make sure that our patients understand how to take all of these and take them make sure they have the best instructions how to take them effectively so that we treat that germ effectively. Preventing airway obstruction in patients with pneumonia includes making sure that they are active, that they can cough. Suctioning might be indicated in some patients to remove an airway obstruction if it's mucus. Promoting recovery from pneumonia means about the same thing, making sure they continue their care if they are discharged. They may need to go to a pulmonary rehab. They need to continue to cough and deep breathe and need to continue to make sure that they keep their airways clear and that they promote opening of the alveoli by doing coughing and deep breathing and activity. Some other things that can help in the recovery of pneumonia is to maintain adequate nutrition to offset extra calories burned during infection. High calorie, high protein diets can help a patient maintain their nutritional needs. A lot of times if you're short of breath, eating large meals can make you even more short of breath because digesting a large meal requires oxygen. We also need to monitor fluid intake and output. Teach them how to control the spread of infection. And think about what this means for us. It means making sure they put their hand over their elbow over their face when they cough, sneeze, things like that. Prevention of aspiration pneumonia would possibly mean an NG tube. Elevate the patient's head and administer feeding slowly. Making sure that if they are nectar thick liquids that we maintain the ordered diet. Okay, moving on to another infectious disease process of the pulmonary system. Pulmonary tuberculosis is an acute or chronic infection characterized by pulmonary infiltrates and formation of granulomas with something called caseation, fibrosis, and cavitation. The American Lung Association estimates that active TB afflicts nearly 5 out of every 100,000 people. Prognosis is excellent with the correct treatment. Mycobacterium tuberculosis is a major cause of TB. A patient will inhale TB, the Mycobacterium infected droplets, and then that's when the battle begins. TB is spread by inhalation of the droplets, and so our job as nurses, and we'll talk about that in the next few slides, is really making sure that we put a patient in isolation who we suspect may have TB. Transmission of TB occurs as an infected person coughs or sneezes, spreading the infected droplets into the air. And someone with poor immunity inhales these droplets, and the bacilli are deposited in the lungs when we breathe it in. Then the immune system responds by sending leukocytes and inflammation to this area when the bacteria is introduced to the person's lungs. After a few days, the macrophages, which are a type of white blood cell, come and ingest the bacilli, and they carry the bacilli off to the lymph nodes. The macrophages will ingest the bacilli and kind of form these tubercle formations, and it's kind of like a little lesions or these cased, encapsulated areas that's kind of like scar tissue within the lungs. So sometimes a patient can be exposed to TB, and the body is able to encapsulate it in the lungs, and the patient never has an active TB. They would have an exposure to it, and what would happen is this TB skin test that we have on a yearly basis would then be positive. And we'll talk about that a little bit more specifically, but the TB skin tests are basically screenings for exposure. They do not mean that a person has active TB. And that's kind of why I wanted to go to this slide. This is an important statement here. Far more people are infected with the bacillus than actually develop TB. Some people may have an exposure and never develop an active TB if they have a healthy immune system. They would be a carrier of it. And like I said, they would probably test positive with a TB skin test. It doesn't mean they have TB. It just means that they have an exposure to it. The TB skin test is a screening tool to determine if people have an exposure and if they're at risk for spreading the disease, because it is highly communicable, so we want to screen people to determine if they are active or not. This slide is meant to be a visual of pretty much everything that I just explained. It shows this transmission here that occurs through droplets in the air. The cavities open into the spread with coughing and it gets into someone's lung, and usually the patient can just encapsulate that bacteria through the use of their macrophages, and it never becomes active. However, some people can have active TB, and usually it's people who have a poor immune suppressant. HIV patients are at high risk for getting an active TB. Or if somebody has maybe other pulmonary issues already, patients with pulmonary disease associated with smoking are at high risk for an active TB. Patients with TB will present with fatigue, lethargy, nausea, poor appetite, weight loss, and a low-grade fever. The signs and symptoms that typically set this disease process apart from other pulmonary processes such as pneumonia is these right here. The low-grade fever, night sweats, cough, and the blood streaked productive cough. The other one is this anorexia and weight loss. Typically, that occurs with a TB. So if somebody presents with night sweats, bloody, productive cough, anorexia, and weight loss, we will suspect that they have a TB. Other questions we are going to ask is any exposure. If they've had any known exposure to TB in the past, if they've been exposed to sick people, what kind of place do they live in? If they live in an area where there's a lot of ill people, that might be another thing that might make us suspect that someone has TB. And then other comorbidities, if they're an HIV patient and they present with these signs and symptoms, we are going to be very suspicious. And the first thing that we do is go ahead and put them into that droplet isolation. And I don't know if any of you have seen anybody. It's a negative pressure isolation. And if you've seen anybody on the floors in a TB precautions, means that they have a special room that has a negative pressure. So basically it takes all the air that's in that room and it takes it throughout a special filter out of the building so that that air is not inhaled by the rest of the patients in the hospital. And then the other thing is at the Christ Hospital, they use the PAPR. And I know at other facilities, they are a special mask that they use in order to, for healthcare workers to not be exposed to the droplets that the patients with active TB are breathing into the air. Again, this is just a visual of signs and symptoms of pulmonary tuberculosis. And like I said, night sweats is a really indicative thing that makes us a little bit suspicious. Coughing up blood, appetite loss, and fatigue are other pretty significant symptoms of TB that kind of helps it stand out from other infectious processes of the lungs. So, like I said, if we have a patient that comes in and they have these signs and symptoms, they're coughing up blood, maybe they're an HIV patient with anorexia, weight loss, night sweats, we will suspect a TB. We will put them into isolation for TB, a special TB droplet isolation. And then we will do some tests to determine whether that is true or not. There's a new test that's listed in your book. It's called the nucleic acid amplification test for TB. It's a kind of like a rapid test now that they've developed, because it used to take us like a day or so to determine whether the patient, so we'd put them in isolation, but we wouldn't know for sure for a couple of days. Now we have this more rapid test that results are available in 2 hours. It's recommended by the CDC that we use this test because it is so quickly. That way we can treat patients appropriately in a more rapid manner. There is a blood test. Quantiferin TB Gold is a blood test that is testing for the presence of the Mycobacterium tuberculosis. Usually results are ready for us in 24 hours with that. That is if somebody does not have access to the NAA test. These are all kind of predictor diagnostic tests for us to kind of continue to keep somebody in isolation. A sputum culture is the confirmation. And as we know, any kind of a culture takes a couple of days, actually a week to 4 weeks to determine whether it's positive or negative. So that's why we've developed these two more rapid. If these are positive, we're going to keep them in isolation. Sputum culture is the confirmation of the Mycobacterium tuberculosis, but it takes too long. So we'll go ahead and, if we can do these two and they're positive, we'll keep them in isolation, and then we'll get the result of the sputum culture in a couple of weeks to help us confirm this. In getting this sputum culture, make sure you understand how to obtain a sputum culture in a sterile container, making sure that the patient, you're getting a productive cough from the lungs, that a patient is not just spitting in a cup. They're actually coughing up sputum from the lungs, because that's what we want. We want a specimen that comes from the lungs. Chest x-ray can show us the encapsulated TB. If a patient has any of these encapsulations in their lungs, it can just kind of confirm that and let us know if there's any other infectious processes going on in the lungs. TB skin test, we know that we get kind of as a screening tool. And again, like I said earlier, it essentially really just tells us of an exposure. It does not mean that you have TB if you have a reaction to the TB skin test. Usually what happens is if somebody has a positive TB skin test, and there is a picture of that in your book, a picture of a positive TB, and it's usually just some redness and a little bit of edema. It just means you're reacting to the tuberculin that they have put in the intradermal injection. And again, it just tells of an exposure. If somebody is positive, we're going to do further testing to determine whether it's an active TB or not. And here's that picture I was talking about. So this is that positive. So it's red, it's elevated. Sometimes people get bruised from these and they think that they're having a positive, but it's got to be red. And people are specifically trained to read these, and it's usually a reaction of 5 millimeters or greater is considered positive. So sometimes people get like a tiny little red mark, but that's not considered positive. It's usually greater than 5 millimeters. Once someone is identified as positive for TB, they have kind of just bought themselves something called combination drug therapy for tuberculosis. It's the most effective method of treating TB and preventing transmission. Oftentimes, this combination drug therapy for tuberculosis is a long-term therapy. It can last 6 to 12 months, and it's expensive combination therapy that has some side effects. So it's patient education with these is very essential. These meds are listed in your book. And first line treatment for tuberculosis, isoniazid is one of the most common medications. An important teaching topic with a patient on isoniazid, which is also known as INH. That's what this one right here. They need to take a supplemental B complex vitamin with this med. This med can cause a peripheral neuropathy, which means like just pain and numbness in their extremities, and with large doses. So vitamin B complex vitamins can help prevent that. One of the major things with tuberculosis medications, the combination medications, is that most of them, the patient should not drink alcohol while taking the drugs. Isoniazid is one of them. So oftentimes patients who have tuberculosis might also we often can find it in homeless patients who are alcoholics as well, so this can be difficult treatment. Rifampin is the next med here. That one you cannot also drink alcohol with it. A lot of them have toxic effects on the liver, and that is one of the major reasons why they cannot drink alcohol with it. Strict adherence to the prescribed drug regimen is crucial for suppressing the disease. Major role is teaching the patient about drug therapy and stressing the importance of taking it as ordered, exactly as prescribed for as long as it's prescribed. It's hard to follow these patients sometimes, like I said, if it's a homeless patient or something like that. That's why TB has been on the rise a little bit more recently. There's been homeless patients who are drug abusers who are passing TB around and not being treated properly because they don't have the money, and of course they're not going to stop drinking. So that's can be a problem with some of this treatment. So again, the first line drugs used for tuberculosis can damage the liver. The patients are highly encouraged not to drink alcoholic beverages for the duration of the TB therapy. And not just for this, but it's also going to help them get better quicker because the decreased alcohol intake is going to make for better nutrition and better health status overall. The following slides are some case studies and questions regarding pneumonia and tuberculosis. Again, as always, I encourage you to try to answer the questions presented, and you can check your answers in the PowerPoint comment section. And this concludes the presentation for Part 3 of Module 8.